give you a wrap-up or review of the hepatitis B related abstracts from AASLD. So, Bob, thanks.
Thanks for having me. Great meeting, great organization. Good morning, everybody. I've been posting pictures on the website app. Hopefully you all can participate too, put questions and comments out. I think it's a great event. Appreciate being here. And of course, hepatitis B has been my love and passion. Being on the B team has been okay because soon we are going to be moving to the A team alongside the NASH group that you heard so nicely from Stephen Harrison. So let me talk about the B world. I like this comment about disclosures because it used to be conflicts of interest, which meant you were guilty until proven innocent. And now we're using the word disclosures, which I think is a little bit softer. And I work with a lot of the people in the hepatitis B space. There's a lot going on here. It's very, very exciting. And you may have heard about the recent Arrowhead funding from Janssen and Johnson & Johnson. That was about a $2 billion deal with initial $250 million investment in the Arrowhead interfering RNA product. I've been working with Arrowhead since 2011. I should have asked for more money, obviously. But it's really exciting to see this technology moving forward. I'm not going to talk a lot about that today. So, inside your app and inside the documents that are on the website are the guidelines. I'm not going to go into great detail because I've got 25 minutes and I really want to talk about the data at the meeting. But the guidelines have been quite interesting with ALT thresholds and DNA thresholds, and the diagrams are very complicated, and the primary care providers are a loss as soon as they open the book. But typically they've been talking about DNA over 20,000 and ALT greater than 2 times the upper limits of normal, especially for E-positive patients. That also overlaps to E-negative patients, but the threshold for DNA to think about treatment is 2,000 international units. This is a large study, about 2,300 patients. They use the new normal, or healthy, women less than 19, 30, and men as being a healthy ALT level. And they're changing terminologies here a little bit to what's called the pre-active phase. We used to call this the immune-tolerant phase of hepatitis B. We're really getting rid of that term because patients really aren't immune-tolerant. They're just being manipulated. Their immune system's being manipulated by the virus, and they have lower levels of inflammation. So you're going to hear different terms for this phase, but probably it's best to call it high replication, low inflammation. That's sort of the best way to describe this this phase of hepatitis B. You may see it in E-negative disease, but you definitely see it in E-positive disease. The bottom line is that these patients with minimal ALT elevations, which is in that mid zone, basically upper limits of healthy to 2 times upper limits of normal, actually are at significant risk of progression. This is risk of liver cancer, and this is risk of death or liver transplantation. Really the take-home message here is, yes, look at the ALT, but more importantly, you need to be looking at FIB4, APRI score, fibrosis on FibroScan. You can also look at fibrosis on ultrasound indirectly. You can look for advanced fibrosis using ultrasound, looking at spleen size or portal vein diameter. You can look at platelet count. I use a very simple threshold for platelet count. Under 170,000, it's F3. Under 100,000, it's cirrhosis or F4. As those patients who have low levels of ALT or healthy or in this gray zone and significant fibrosis are at high risk for progression, and we really need to move, I think, our threshold down to treat. Okay, let me see if I can get this to work correctly. Okay, so S antigen loss, the annual clearance rate in patients who are not being treated, who are chosen not to be on any type of nuke, the annual clearance rate's about 1.3%. The best we see on nukes right now with entecavir or TDF, the earlier version of our tenofovir analog, is about 10% after 5 years of chronic suppression in compliant patients. And that 10% is typically in E-antigen positive patients. I'm going to talk about e-antigen negative patients in a few moments in terms of how you manage those patients and discontinuing therapy. The current guidelines say treat your hepatitis B patients until S loss. There are algorithms in E-positive patients to stop treatment when they meet a threshold of DNA negativity for a certain period of time and their E positivity has gone to E negativity. But in general, we're treating till S loss, and all the new drugs that we'll talk about at the end, those companies are pushing for S loss, and I'm telling companies don't invest your $2 billion in a new hepatitis B treatment unless you can get to S loss at 40% with 18 months of treatment / follow-up or less. So that's usually 6 to 12 months of treatment, 6 months of follow-up. If you're not going to predict an S loss rate of 40%, don't take your drug forward. Think about combination therapy. Think about sequential therapy. So that's just a Bob Gish number, but I'm just trying to tell you what I think the threshold for these incredible investments. Okay, so now we're talking about these patients in this gray zone, ALT 1 to 2 times the upper limits of normal. This is a TDF trial for this minimal elevation of ALT. And we're talking about fibrosis status here at 3 years of treatment with tenofovir, very small number versus placebo. So basically what we're describing here is less progression and even potential reversal of disease in long-term TDF treatment. That's our previous Viriad. I'm talking about previous because of tenofovir alafenamide or TAF that's on the market now, Vemlidy. So really we're talking about reversing fibrosis in our treatment patients, picking patients who have fibrosis using your non-invasive testing. Unlike NASH that you heard about from Stephen Harrison, everybody's getting biopsies or trying to get biopsies in these phase 2 studies. Liver biopsies are fading in clinical practice, but fortunately, these large trials that are still taking place with TDF and now TAF are getting biopsy information for us. We are seeing a benefit. Okay, now I'm going to move to another hot topic. So e-antigen negative patients are being treated because they have often more active disease or are actually at higher risk of progression if they're E negative and are replicating E negative elevated ALT. There's an E negative population who are non-replicating. Those patients basically have just better immune control, but E negative patients that you chose to treat are actually a major part of the global population of hepatitis B patients today. So if you're in Australia, US, Europe, Canada, 60 to 70% of your patients that you see that are replicating are coming in with e-antigen negative disease. These patients have core and pre-core mutations. You can actually measure those in clinical practice by sending sequencing specimens to LabCorp or Quest or ARUP. We don't do that. If you've got a DNA that's over 2,000, e-antigen negative, those patients have core, pre-core, or dual mutations. They're not making much e-antigen, but they're replicating, they have active inflammation, they've undergone a mutation to get a little bit better of immune escape. These patients, natural history, almost never clear S antigen unless that DNA somehow has gone to negative. So you've chosen your patients to treat. Should you stop treatment? So I'm going to show you at the end of this next set of slides the really good news. I'm going to show you some bad news here at the beginning. The good news is historically that people were claiming you stop nukes in an E-negative patient and you can get 20 to 30% to lose S antigen after they go through a relapse, a mini flare, and then their immune system gets the virus under control. This is a prospective randomized controlled study, phase 4, mostly Asian patients, and they discontinued nukes in 45, they continued nukes in 22 of these patients. I don't agree with this endpoint. I want DNA undetectable S antigen loss to say that I've had a favorable effect, but they put the threshold a little bit lower here. And in this, we basically saw very, very few patients who had S antigen loss. That's really what we want to see. Sustained response was also very low. So basically, E-negative patients, Asian population, you take them off a nuke in this study population, very few lost S antigen, and very few had this viral control, 2,000 suboptimal, but still there. So I'm giving you the bad news first. This is just a little bit more information about what happened to those patients in terms of clinical relapse and how many of those patients went back on treatment. So this is going to state in an Asian population, you may not be getting to this more favorable off-treatment sustained viral control. This is really important. Who will need retreatment? Now I'm moving from Asia to now a European population. This is the same population that Paul was talking about a little while ago in terms of liver cancer risk, but I'm going to really back up and just talk about these patients who are on treatment and then went off treatment, and then combined some Daring B, this is European, from a finite study, which is a study that was done in Asia. So take-home message here is that we have a new test that's available in the US. It's been available now for almost 2 years from Quest, and it quantitates hepatitis B surface antigen. This test that's been made by Roche and Abbott's been available all over the world for probably 15 years. Roche and Abbott decided not to take it through the US FDA to get it approved, but there's over 200 articles on quantitative S antigen talking about correlation between S antigen and viral clearance, cancer, risk of transmission, risk of cirrhosis. Lots of data, and Quant S, in my opinion, should be part of your clinical practice, and you should be testing every B patient baseline for Quant S and probably doing Quant S once a year. So if you have a low S antigen quant that's less than 100 IUs per ml, this is percent remaining without S antigen loss. That gets quite confusing. But actually, I'm now going to invert this and say the number of people who lost S was 80% if their quant S was less than 100 before stopping therapy. So you can say in your E-negative patients whether to take them off or not just by doing a simple test. It's about maybe $180 through Quest, the retail price. Get that number back. If it's under 100 or under 150, I would say take them off a nuke and monitor them closely, and I'll get to that in just a moment. Another assay we don't have commercially available in the US yet. This is from Fuji Re-Bio. They came up with what's called a core-related antigen. Hepatitis B makes core antigen. That's why we have core antibody testing. It also makes E, which we talked about, and it also makes another protein, which I think is called a P100. That combination of 3 different antigens now being measured in this assay, correlated antigen, which relates to the activity of cccDNA, what's actually going on in the nucleus, the stable intermediate of the virus. And this correlated antigen also helps predict who's going to come off therapy. You're going to hear more about the correlated antigen over the next few years and a little bit more today. So we really have a need for biomarkers to assess the risk of treatment withdrawal, the success of treatment withdrawal. But S antigen keeps coming through as a powerful, useful tool that's available clinically, available commercially in a variety of different trials. So I'm really trying to sell you on S antigen assessment in your patients. Again, at baseline, on treatment. If you have somebody who's not on treatment, it's got a low viral load, you can watch that S antigen go down numerically over time, and you can predict they're going to clear. If they've got a low viral load, some fibrosis, the S antigen's in the 1,000 range, they're never going to clear on their own. That's a patient I'm either going to put on nuke treatment or I'm going to think about putting in a clinical trial. So now I'm going to get to the good news. This is an extensive number of different papers, including one with Hadzianis, with Adefovir, a drug that we don't use anymore. With you stop treatment, you stop nukes, you look for relapse, you look for DNA change, ALT change, monitor those patients long term, you have a very substantial chance that they're going to be clearing S antigen after a treatment duration of 3 to 5 years and monitoring them for another 3 to 5 years after stopping treatment. We can get to S loss in a large number of these patients. But it's really back to get that quant S, help select those patients who you're going to take the risk, and I'll get to the risk story in just a moment. So who else? Older age has a higher chance of clearing S. There's some time. There's some ethnicity involved, which also has to do with genotype, what genotype is present. how long it took the DNA to become undetectable on the nuke, and maybe DNA undetectable after what's called a flare or mini flare afterwards. S antigen levels we talked about. We haven't really proven there's a difference between TDF and entecavir for S antigen loss, but the data with TDF is much more robust. Entecavir did what was called an adaptive study design. Lots of patients came off treatment after they met an endpoint. In tenofovir, the TDF and TAF trials, they're block study designs, and you have a lot more patients that you're retaining on treatment. So S antigen is the take-home message. 100 to 150 is the magic number. There's a chance they can come off treatment. Other things in clinical practice, I'll get to that in just a moment, which I'll be talking about flares. So there was a little controversy out there when entecavir was being developed in animal models at very high doses. It actually had some hints of being a carcinogen. I was involved with assessing that carcinogenicity risk. This was way back in 2002 and 2003. And I, the FDA, the company, toxicologists all felt that that risk was minimal because the doses in animals, human relative doses would be about 70 years with about 70 times the exposure you would get as a human. We didn't think that was relevant. But now we've got TDF and TAF, and then there's a question is, are we going to lower cancer risk further? Since entecavir doesn't increase cancer risk, but is TDF or TAF better at lowering cancer risk? And Dr. Yim from Korea had some very interesting data that was published in JAMA Oncology. And actually, I'm just going to back up one, sorry. And the bottom line is that looks like TDF is better than entecavir in terms of cancer risk long term. And I'm going to explain this by better suppression of virus. I think there's better intracellular suppression of virus with TDF, and I think that's also true with TAF. TAF actually has a better rate of ALT normalization compared to TDF, which is kind of interesting, and that may also have to do with better intracellular concentrations of TAF. So in my practice, I'm either using TAF or entecavir. Entecavir I use in San Diego where I work with a FQHC, because entecavir is about 50 cents a pill. That's very, very low price. We go there first. I'm using TAF in my practice because I think it's got better bone and renal safety, better ALT normalization, and may have some benefit in terms of cancer risk. One very short discussion here about taking TDF to children. We actually have entecavir approved in a liquid form for pediatric patients. There was a study that took a very long time to get done, but was finally done, down to age of 2, showing very, very nice DNA negativity and ALT normalization with TDF in children, lower dose than we would use in adults, or lower total dose, but it's 8 milligrams per kilo. I want to remind you that Gilead never did a dose ranging study with TDF in adults. They chose the 300 milligram dose because that's what was used in HIV patients. But good news is now we have TAF, it's 25 milligrams instead of 300 milligrams, and that also may have some relationship to its reduced bone and renal toxicity. So flares were a super hot topic at AASLD this year. Everybody's worried about stopping drugs. There's a black box warning about not stopping hepatitis B drugs, or you can stop, but you need to monitor patients closely. So really, what is a flare? What's the frequency of flares? When is that a danger to a patient? So we have to define that. I like to use the ALT 5 times the upper limits of normal. So if the upper limits of normal, say, is 30, if you get an ALT over 150, you need to be concerned, or more than twice the baseline value. But you're really going to be concerned if the bilirubin's increasing, so you always need to know a baseline bilirubin level. And then there's a number of other factors that are involved with these flares as well. I tell my patients if they're non-cirrhotic, the risk of a flare that would result in decompensation, death, or transplant's about 1 in 800. I think it's quite small, but that's a triple, monitoring of those patients and monitoring liver function. You have to look for other causes of a flare. We'll talk about delta hepatitis very briefly in a moment because my time is going to be running out shortly. But you need to be monitoring those, monitoring DNA levels, monitoring liver panels, liver enzymes first, liver function present. And the basic rule is don't stop treatment if you have a hepatitis B patient who's got cirrhosis. It gets a little controversial. You have a cirrhotic patient on a nuke, they've lost S antigen, but they still have cirrhosis. What do you do? And that may be time to get special hepatology consultation. Okay, biomarkers. We're doing a lot in drug development. There's over 30 drugs being developed for hepatitis B today. Remember, when you measure S antigen qualitatively, you have this cutoff of 0.05 IUs, which is arbitrary. Because once they clear S antigen, they're still making S antigen. Their level might be 0.04, but at least they've had S loss. But you also need to look at that combined with DNA, less than LOQ, which is now in the 12 IU range. Very, very sensitive assays that we use. Quant-S you can use in your practice today, but it's part of all the new drugs that are in development. Correlated antigen and quantitative HBV RNA are major targets in terms of new drug development. E-antigen concentration, we can actually get that done in many countries throughout the world. Abbott's got a great e-antigen quantitative assay. We can't measure CCC DNA yet because we're not doing liver biopsies on most of our patients in our trials, but correlated antigen and HBV RNA quant correlate with CCC DNA activity and probably the semi-quantitative presence of the CCC DNA in the liver. Delta hepatitis, very hot topic. This is a place that I'm doing lots of research, publishing. I'm working with Iger. And I just want to highlight that there's data in the US that in your S antigen positive patients, the prevalence of Delta antibody might be about 12%. And of those patients who are Delta antibody positive, about 70% are replicating. You can get a Delta RNA quant through ARUP, and Quest will probably have a Delta RNA assay clinically, commercially available for you in your practice by February of 2019. So 12%, and then you say 9% are replicating. They've got replication. Their risk of death with Delta is 70 to 80%. You need to know, in my opinion, every S antigen positive patient, their Delta status. Definitely should be ordering it. I think it's standard of care in a B patient who's replicating, has got advanced fibrosis, elevated enzymes, any marker of significant liver disease, you need to know their Delta status. And that's being hinted at in the guidelines. All right, we're going to wrap things up here. I got about 3 minutes left. John, I'm trying to stay on time. This is a very complicated virus. I'd say that, hepatitis C looks like a bicycle and hepatitis B looks like a Porsche 911 S-Target. I mean, this is really a different virus. It's a DNA virus. DNA viruses are never cleared, never cured. You have a patient who's got core antibody, they have CCC DNA in their liver. They don't need a vaccine. They need to be monitored and educated about hepatitis B reactivation. So companies are spending hundreds of millions of dollars, investors are investing hundreds of millions of dollars in hepatitis B because we can block entry. We can target CCC DNA through destruction, inactivation, CRISPR-Cas9, other compounds. We can target HBV RNA, maybe by destabilizing or enhancing RNA ACE. We can block capsid in packaging. That core antigen is part of a capsid formation for the virus. We can target DNA synthesis. We're already doing that with our nuke therapy. And we can target assembly and export of this virus. And very importantly, we can target the innate or adaptive immunity through vaccines, through different types of interferon, through oral therapies like a company called Springbank Pharmaceuticals. I don't have enough time to go through all these new drugs. I'll ask next year for an hour for that, maybe we could get. But what's happening is capsid modulation, capsid inhibitors, CPAM, super hot topic. The bad news is in the first 12 weeks of all these different drugs, there was no effect on surface antigen, but great reduction in core antigen, correlated antigen production. But one drug that's actually being developed in China with a colleague of mine in Jilin, they actually started seeing an S antigen decline between 12 and 24 weeks. So we're actually starting to see that these capsid inhibitors stop virus release, and they're actually having a feedback loop and decreasing CCC DNA production, regeneration, and activity. So I think capsid inhibitors may be a backbone of our future therapies, but I'm putting myself a little bit on a limb. So Check all surface antigen patients for Quant S. Functional cure, it's a bit of an oxymoron, but that means S loss and DNA undetectable. We're looking for maybe about 40% of that in our patients in the next 5 years. Think about new thresholds for healthy. The AASLD just came up with this 25 instead of 20, 35 instead of 30. But really don't pay attention to what your lab calls normal. Think about what's healthy. Check for delta. We talked a lot about TDF and definitely some inference about TAF. And definitely TAF has got less bone and renal toxicity, so it should be consideration. But entecavir also has no bone or renal toxicity. And all these drugs decrease liver cancer risk. Hepatitis B, stop alcohol use. Look for NASH in those patients. And stopping nukes, we talked about how to do that in your practice. So 5 pillars I call about hepatitis B. Test all immigrants for hepatitis B surface antigen, and when you check for B, check core antibody and surface antibody. Core antibody means they've been exposed. Core antibody means they still have cccDNA in their liver. Don't waste money, vaccinate, but do educate those patients about risk of reactivation. Vaccinate all adults who are triple panel negative. Think about this ALT issue, but think about APRI, FIB4, transient elastography in your patients. And treat till S loss unless you want to look at some type of protocol about discontinuing therapy. Thank you very much for having me.